And good evening, friends and colleagues around the world, and welcome to this webinar, this digital event, Antimicrobial Stewardship Data in Action, organized by the International Pharmaceutical Federation and the Commonwealth Pharmacists Association. My name is Lars-Åke Söderlund, and I will be co-moderating this event today, together with Francis Garrigan and Maxencia Nabirio, from the Commonwealth Pharmacists Association. And it is my pleasure now to give the floor to Francis to introduce us to today's webinar.
Thank you, Lars. Hello, everybody. Today is the third in a series of 6 webinars, which we are running in partnership with FIP around antimicrobial resistance. Our series will culminate in a symposium during World Antimicrobial Awareness Week, where we hope to showcase some of your own innovative practices in tackling AMR in your countries and regions. My name's Fran Garrigan, and I'm an antimicrobial stewardship pharmacist based in Manchester in the UK. And as well as working in secondary care in the NHS, I have the great privilege of being the AMR Technical Programmes Lead for the Commonwealth Pharmacists Association. And I'd like to tell you a little bit about our organisation. The Commonwealth Pharmacists Association is a charity that was set up in the 1970s with the goal of helping to support the development of the pharmacy profession and the safe and effective use of medicines across the Commonwealth. The Commonwealth is a network of 56 independent countries who've signed up to a charter of shared values, committing to work together to create a better and fairer world for all of the citizens of the Commonwealth and progressing the Sustainable Development Goals. The Commonwealth encompasses around 1/3 of the global population and some of the poorest nations of the world. And our mission as an organisation is to work in partnership and leverage the strengths of our network to support the development of the pharmacy profession through our relationships with national pharmacy associations of the Commonwealth. As many of you may know, LMICs are disproportionately affected by antimicrobial resistance, and this has become one of the areas of focus of our programmes of work over the past 4 years. Since 2018, the CPA, in collaboration with our partners, the Tropical Health and Education Trust, have pioneered and run the Commonwealth Partnerships for Antimicrobial Stewardship programme. This involves partnering health institutions in the UK with health institutions in 8 African Commonwealth countries to help deliver on their AMS action plans with a real focus on improved antimicrobial stewardship and infection prevention and control, combining this with developing leadership capacity of pharmacists in this area. The huge success of these programmes has been down to the dedication of pharmacists, both in the UK and Africa, and the multidisciplinary teams that they've worked with. And this programme has not only seen direct benefits to health systems and patients, but it's really raised the profile of pharmacists in this space. We've now reached phase 2 of the programme, and we've recently launched a call for applications in the next round of partnerships. If you'd like more information, please look on our website. We've delivered many other programmes around antimicrobial stewardship, including developing an app to increase the accessibility of our guidelines and international and national guidelines across 22 lower middle income countries, really trying to support countries to use the prescribing guidelines and also collect data to bring about changes in practice around antimicrobial stewardship and prescribing. And we're delighted that FIP have asked us to lead this webinar series on AMS, recognising our work in this space and our collaboration with other organisations. It's a great example to demonstrate the collaborative working between our 2 organisations who have so many shared goals. And I'm delighted to hand back over now to Lars to give a few more words. Thank you, Lars.
Thank you, Francis. It is indeed a great privilege for me to be able to co-moderate this event today with Francis and Maxencia. And my name is Lars-Åke Söderlund, and I am a community pharmacist from Stockholm, Sweden. I am also the immediate past president of the community pharmacy section within FIP and currently one of FIP's vice presidents. It's a real pleasure to be with you here today. I am also very excited about today's event, number 3 in a series of 6 events, and I am convinced that today's event will bring lots of value for all the pharmacists in different settings in all pharmacy disciplines. The International Pharmaceutical Federation, FIP, is the global body representing over 4 million pharmacists and pharmaceutical scientists. We work to meet the world's healthcare needs. And FIP is a non-governmental organization that has been in official relations with the World Health Organization since 1948. And our vision is a world where everyone benefits from access to safe, effective, quality, and affordable medicines and health technologies, as well as from pharmaceutical care services provided by pharmacists in collaboration with other healthcare professionals. Our mission is to support the global health by enabling the advancement of pharmaceutical practice, sciences, and education. And the issue of AMR and AMS is one that is very close to all of our hearts. As pharmacists, we all have a real responsibility in this area, and FIP has been working in this area for many years, culminating in a position statement. FIP was pleased to contribute to the WHO's consultations to develop the Global Action Plan on Antimicrobial Resistance that was subsequently adopted by the 68th World Health Assembly. And at the 74th World Health Assembly in 2021, FIP reiterated to ministers that the pharmacy profession around the world is committed to being part of the solution to antimicrobial resistance. And in a statement to the Assembly, FIP reported that at least 144 countries have a national action plan on AMR, and that it had called on its national pharmacy associations to take an active role in the development and implementation of these plans in a statement of policy on the control of AMR. And FIP continues to facilitate the essential contributions of the pharmacy profession to AMR reduction around the world, for example, through surveillance and monitoring of antimicrobial use and resistance, antibiotics distribution and regulation, and is driving action through the FIP Commission on AMR, which is comprised of pharmacy experts with international reach and diverse backgrounds. And the Commission's work is solely focused on AMS. And they are in line with the FIP development goal number 17, antimicrobial stewardship. And this development goal is a goal regarding antimicrobial stewardship for the entire profession. And the work of the Commission is now going to be consolidated into a 12-month work program where the Commission will set out the training and education needs, raising the advocacy and policies needed in all regions to address AMR. And this is where FIP will focus its intention. But of course, these challenges need to be done in partnership, and this is where we need to collaborate. And within FIP, we don't seek to duplicate work done by others, but to partner and collaborate when possible to solve these challenges. And we are indeed very, very proud that CPA has chosen to partner with FIP for this work. The legacy that CPA has in this area is a huge amount of training resources addressing AMS, and to some extent fills in the gaps of FIP. And we are now in a position where we want to make sure that this great work is spread worldwide. So it's really important today that we continue this collaboration in a very meaningful manner. We have been collaborating with the CPA for many years, and we need now to deliver the real benefits of our of this collaboration to members worldwide. So in the next slide, we will see some housekeeping rules for today's event. This webinar is recorded and live streamed via YouTube, and the recording will be available on FIP and CPA websites. And of course, we encourage you to ask questions during the event, and please use the question box provided. And you can also use the hashtags CPA Farm and FIP Digital Event by tweeting on Twitter. And I also encourage you to become a member of FIP, and you will find all the details at our website. So for today's program, we have a full complement of most distinguished speakers to share their experiences with us and to explain what methods and data can be captured to inform how antimicrobials are used in different healthcare settings. How do we know if antimicrobials are being used appropriately and whether there is a scope to make improvements? So these sessions considers point prevalence data to understand antimicrobial use and how the data can be utilized to implement change and how to embed that change to create a sustainable action. So I will also, before we continue, bring to your attention that all the participants will receive a certificate of attendance after the event. And if you attend all the 6 sessions, you will also receive a specific certificate for all the 6 events. So thank you so very much. I now hand over to Francis again.
Thank you. So we would really love you to share your innovative AMS solutions with us. And there's a chance to win a prize and also have your winning entry showcased at our final symposium, which will take place during World Antibiotic Awareness Week. Please use the link on this QR code and fill in the form, and good luck. We really are excited to see your innovative solutions. So these are the learning objectives from today's session. And I will move forward to introduce our first speaker, who is Anne Vesporten. And I have had the pleasure of working with Anne on a number of different projects. I'm really excited to hear what she's got to say to us today. Thank you, Anne.
Thank you for inviting me for this great webinar. I'm very pleased to meet everybody. I think several of you will know me already, but several will not. So I'm very happy to talk about the global PPS on antimicrobial consumption and resistance, which will allow you to collect data for action. So next slide, please. So, okay, first of all, introduce myself. I'm working at the Laboratory of Medical Microbiology at the University of Antwerp in Belgium. I have been in charge of several surveillance programs before I joined the University of Antwerp in the Scientific Institute of Public Health, which is called now Scienzano. I have been working there for 10 years. So, but since 2010, working at the University of Antwerp, I have been working and been responsible for several European projects. I've listed them there if you're interested to look what they are all about. I'm actually also working partially for the Belgian Antibiotic Coordination Committee of the Belgian government, and I'm there also responsible for the hospital medicine subgroup. But since 2014, I'm being helping, coordinating, and doing the data management of the global PPS. So that's what I'm going to talk about today. So next slide, please. So the learning objectives of this short presentation, for those who doesn't know yet, get you to know the global PPS, which is a standardized, simple tool to capture data on antimicrobial prescribing, antimicrobial resistance, and also healthcare-associated infections. What are the benefits for your institution of participating to the global PPS, and also how the data you will be collecting will help you to implement antimicrobial stewardship actions. And at the very end, it's meant to improve prescribing in the hospital, how you can embed those changes to create a sustainable action, which is also very important to be sustainable. So next slide, please. So what does the global PPS offers? A standardized, feasible, and sustainable surveillance method for monitoring antimicrobial prescribing, resistance, healthcare-associated infections of inpatients admitted to hospitals worldwide. So we offer a standardized protocol and a data collection templates, all the materials. And beside that, we also have a web-based tool where you can enter the data, you can validate your data. It's very important to collect valid data, so there is a quality assurance there embedded. And also we provide a feedback report with benchmark results for the country and the region. So actually it allows you to build up your own standardized database on healthcare-associated infections, antimicrobial prescribing, and resistance. And because you build up it in a standardized, simple way, it also facilitates repeated PPS. There is guidance throughout the process. You're not alone doing that. So all the data are freely available, but also there is free central support by the Global PPS support team. Not only myself, but I also have a nice colleague, Ines Powels, and the IT support. We are all there to help you to get sustainable action on antimicrobial stewardship. Next slide, please. So what makes the Global PPS unique? First of all, it is meant to identify the burden of antimicrobial resistance prescribing in your hospital. So the Global PPS enables you to determine the variation in drug, dose, and of course the indications of antimicrobial prescribing in a standardized manner. And also you will be able to assess a broad range of quality indicators, international adopted quality indicators for appropriate antimicrobial prescribing. Next, when you have collected the data, it is meant to change practice. You have to identify targets to improve antimicrobial prescribing and also risk factors for healthcare associated infections. With the Global PPS, you will be able, hopefully, to do that. So it also helps you to design tailored stewardship interventions to raise awareness within your team in the hospital and also to promote appropriate antimicrobial prescribing. Because we always strive really to come to a simple tool, you should be able to measure the impacts and assess the effectiveness of interventions you have set up in your hospital through repeated PPS. Next slide, please. Thank you. What are the features of the Global PPS surveillance tool? It's freely available. So actually, any hospital worldwide admitting inpatients can participate. But participation is on a voluntary basis. But there is no remuneration foreseen for the hospital. Unfortunate. Participation can be done as an individual hospital, but also with the hospital network. And I've seen here people joining us from, for example, the Philippines, where the Global PPS is run by the Ministry of Public Health, and where they can centralize data entry, which is very nice, because then you have access to all the data and have the whole network with you. Important to say also, I felt, because we got a lot of questions on that, which is completely normal, patient level data entry is completely anonymous. It's pseudonymized information. You can consult us protocol where you find more explanation on that. And the data are strictly confidential and safely stored on a secured server at the University of Antwerp in Belgium, because we use a web-based tool for data entry validation and feedback reporting. Next slide, please. So how would you organize at hospital level? We believe really you can't do that on your own. So it is really in your advantage to create a multidisciplinary antimicrobial stewardship team with a lot of professionals involved there. Promote and communicate. We think it's really important that you seek support for the efforts you're going to do in your hospital on appropriate antimicrobial prescribing. We offer for the moment, three survey periods a year. So January, April, May, August, September, December. And every hospital is free to participate in just 1, 2, or all 3 survey periods a year. So that allows you to do repeated participation, repeated survey. And you can do that even with the selection of ward types. If you, for example, identify issues in specific ward types, you can survey those specific ward types for the next time or the third time or even afterwards also. Next slide, please. So how would you then, when you have collected the data, move towards the development of antimicrobial stewardship actions? So one thing is important to get your results, to look at your results. So the Global PPS offers real-time feedback reports, which are there actually for you to use for local communications and also target setting of antimicrobial interventions. We have 3 kinds of feedback reports. Whenever you participate for the very first time, you will be able to download what we call a 1-point feedback report, where your own hospital results will be compared to results of the country, the region, and also European results we provide as well. Whenever you participate multiple times, you will be able to download a longitudinal feedback. And for those participants who are in charge of a set of hospitals, a network, which I have been talking before, you will be able to download merged feedback reports for a set of hospitals. So I invite you to look at a 1-point feedback report, which is anonymized, available on our website. You can find it on that on the website shown there. Next slide, please. So what can you obtain? Important. What are the antimicrobial quality indicators obtained from the Global PPS? First of all, prevalence of antimicrobial use, but also you will get rates on how much community acquired and how many healthcare associated infections do I encounter in my hospital. What about medical and surgical prophylaxis? Also the classes of antimicrobials being prescribed. Is it more broad spectrum or more narrow spectrum? We also provide results using the WHO aware classification, the ratio access wash antibiotics. What about this one for specific indications? What kind of antibiotics are prescribed for particular infections? What is prescribed for pneumonia, for sepsis, urinary tract infections? It's all in there. And also surgical prophylaxis. Next slide, please. So another set of quality indicators are, for example, what about local guidelines? Are they missing for certain indications? And if they are there, are the antimicrobial prescribed according to local guidelines? Is a reason for the prescription being prescribed, the duration or the stop date being recorded? What about antibiotics for surgical prophylaxis? Whether there is microbiological results being available. So is the antimicrobial treatment targeted? So it's a whole list. I'm a little bit fast here. Maybe go to next slide. Thank you. Again, we do believe it's really important to come to effective communication of results in all kinds of ways. That is utmost important. And so that's why I don't mind to give you this slide as well. Give feedback to everyone involved, the prescribers, pharmacists, infection control nurses. It's important to increase awareness on antimicrobial stewardship in the whole hospital. So everybody is actually part of the game. So it will also help you to increase ownership of those different groups in the hospital's antimicrobial stewardship activities. Another one we do believe it's important is to report to the hospital management. It can help you whenever you have real data in your hands. It will help you hopefully to obtain resources from the hospital management for antimicrobial stewardship, or to obtain resources for diagnostic capacity, I'm just saying. So, and then another one beside communication of results, you need to make a choice in which kind of tailor-made stewardship interventions you want to implement, and then repeated Global PPS. So next slide, please. So please, that's my short presentation. Get in touch. I'm providing you there the website and our email address. Any hospital can participate. You're really very welcome to join us still in 2022 or anytime in 2023. Thank you very much for everybody.
Thank you so much for contributing, Anne. It's really great to see the development of the Global PPS project and the programme and where it's going to be used in future, and the impact that this has on our ability to collect quality data to guide us in our antimicrobial stewardship programmes. We're going to bring you back in at the end, Anne, for our Q&A session, so we will see you again then, but thank you so much.
Thank you.
So I will lead us into our next speaker now. And just before I introduce Lena, just to remind people, we do have the facility to input questions into the chat box that we can then look at during the Q&A session. So if there's any questions you'd like to pose to our speakers, please do that. So I will then introduce Lena Al Hassan for our next talk. Thank you very much, Lena.
Thank you all for inviting me to this event, and I'm really happy to be sharing our experience in establishing this international interdisciplinary network to tackle antimicrobial resistance. Next slide, please. So just to give you an overview of why we kind of came together as a group to establish this network. So we recognize, and I'm sure you all agree, that antimicrobial resistance is a global health issue that is a cross-disciplinary issue as well, that requires several stakeholders in order to address, not only solve, but also to address. And I think in response to perhaps policymakers and also an increased interest from research funders and calls, there is an emerging community of researchers who are interested in interdisciplinary research globally. However, we have noticed that obviously different disciplines have different working practices, logistical issues, the use of different languages and scientific norms. So it adds an extra challenge of being able to form adequate collaborations in light of these differences. And also the outcome of research from these different disciplines can be quite different and can be interpreted and applied in different ways by researchers as well as policymakers. We also recognize that low and middle income countries have a much higher burden of antimicrobial resistance than high income countries. However, research activities are much lower and less in low middle income countries and are quite limited by limited funding and limited capacity. Next slide, please. So I think in our experience in developing an kind of an interdisciplinary network on AMR, it is really important that to recognize networking within and beyond your own discipline. I think this is the key to developing an interdisciplinary research collaboration, really, is to being able to network and find the avenues for collaborations through these networking events. These networking events lead, as I said, to new collaborations, but also facilitates knowledge and expertise sharing among different researchers. And I think there is an increased availability of platforms which facilitate and promote networking through several networking events, through funding bodies, within universities, within scientific societies, but also more interest and perhaps a little bit more funding available now from different institutions to support this kind of networking events. And there are a few grants that are targeted specifically for networking across disciplines. And the networking allows future partnership and future funding opportunities, and it brings together individual researchers with common interests. Next slide, please. Just to give you an overview of how TACTIC, which is the abbreviation for our group, was. And it's all happened through these networking events. We're lucky within my institution, Brighton Sussex Medical School. We are based within the University of Sussex in the UK, and we have a strong interest of academics working in global health. So we have come together and across different schools, across the medical school, across international relations, development, political science and law, among others. We've come together to establish this kind of informal, if you like, Sussex Global Health Group, where we have regular meetings once every term, really just to come together to share ideas and just experiences generally in global health. And then within that group, there was an interest that kind of emerged, several of us that were interested or working on AMR. So we then kind of established a subgroup of the Sussex Global Health Group that was the Sussex AMR group. And we were meeting kind of to discuss potential projects where we could collaborate. And it's an interdisciplinary group of researchers working in the medical field and microbiology and the biomedical sciences, but as well as political science, international relations, anthropology, development. And then we were lucky that the University of Sussex had an internal grant that promoted international collaborations and establishment of partnerships and networks. So we applied for that and building on our own individual research network and the wider research networks within our disciplines to establish tactic. Next slide, please. So just to show you the diversity and within the network, both kind of in terms of locations globally, but also in terms of expertise. And so when we came together at Sussex, it was mostly myself from the medical school, but also from international relations, my colleague, and we kind of brought in our external networks as well to participate, our colleagues from Spain, Germany, Canada, but also from Africa, from Egypt, Sudan, Ethiopia, Zambia, Cameroon, and just to kind of provide as much expertise, as much diversity within the network as possible, all of us with the shared interest of looking at AMR. And obviously medics and pharmacists were crucial, particularly in our partner countries in Africa. So we have within microbiology, international relations, infectious diseases, also colleagues in mathematical modeling, looking at prediction of AMR emergence, but also more kind of in global health and veterinary science, and also pharmacists. Next slide, please. So the objective of the network was to bring together researchers to advance the understanding of the global spread of AMR by bringing together researchers with diverse expertise and skill sets in the epidemiology of antibiotic resistance, and also to strengthen cross-disciplinary research on AMR, to develop common research questions, because what we have noticed is that a lot of the times people are working in their own individual discipline, and due to kind of all of us being engaged and busy with our own work, that we don't really emphasize, or we don't really hear about the importance of collaboration, and also to hear from, for example, social scientists and how they would investigate AMR is quite different to biomedical sciences as well. So we wanted to be able to come up with common research questions and enhance research designs that combines this interdisciplinarity. And because of our interest and our links within global health and our collaborations with low-middle income countries, we wanted to integrate the kind of our external partners' research networks in low-middle income countries to build capacity for local scientists to be able to produce high-quality data and provide mentorship to early career researchers. Next slide, please. So just a timeline of events since we established Tactic, which was back in 2016. So we got the Tactic, which was the IRPN award, and then we had our first meeting in Brighton, where my institution is based, and then we had a series of meetings in Cairo, Barcelona, Amsterdam, and then kind of ongoing. And unfortunately, due to COVID, we kind of had to rely on virtual meetings, but we still managed to keep the group together, but also expand the group even more. And I will go through the different awards that were and the different projects that have emerged due to the establishment of Tactic. Next slide, please. So I just wanted to highlight the kind of the successes of working internationally, collaboratively, and how we can make that success. It is obviously very challenging, and I'll speak about the challenges, but I think shedding a positive note first, the success is primarily based on the interest and motivation of individuals. Really, I think it all comes down to the individuals. Obviously, the institutional support is very important to provide researchers or individuals with the time and the opportunity to network and to partner and to collaborate with externals. But I think to be able to make that commitment, it has to come from the individuals, the chemistry between them, and most importantly, to want to share the knowledge and expertise. It is also important to have a mix of experiences within the international research collaborations, from early career researchers to senior researchers to professors, medical in the medical field, in the pharmaceutical field, but also in social sciences and kind of beyond. And also to provide opportunity for mentorship, capacity building, and growth of the network, and be able to attract other partners, other collaborators, kind of as you go along. And very important is trust between the individuals. When you share data and you share expertise, that it's going to be used kind of in the right way, that no one is going to be taking the data and doing the research with it, and that we are giving something back. It's a mutual trust relationship. Next slide, please. And then to build on also the equal collaborations and the trust is the collaboration has to come quite equally, through the network and through that international setup, really, because there is an increased interest across all disciplines in forming these international collaborations. It is important to note who are you really collaborating with, and the need for this coordinated global response. It's really difficult. So you have to think about equality and also sustainability, particularly in the North-South collaborations, because unfortunately, a lot of the times, researchers from the North, they do the research in the South, but they don't give a lot back to the local researchers. And it's really important to provide opportunities for local researchers to be involved, not only to kind of give us the data and we will work on it, but to recognize the importance of equality and also sustainability. The duration of funding is usually for, an X number of years. How can you make sure that what you're doing is sustainable in the long term? Locally. So the main thing, I think, is capacity building should be included as the main element when working with early career researchers in low and middle income countries. And then facilitate knowledge exchange, because I think there is a lot for us to learn as well from these North-South collaborations. And there is a lot of expertise and a lot of knowledge with our partners that we must recognize as well. Next slide, please. However, these interdisciplinary networks and collaborations, they come with several challenges, and it's only when you start working interdisciplinary that you start recognizing these challenges and how they present themselves in different methods, in different terminologies, and even writing styles. And a lot of the times, it's a fine balance to kind of be able to present outcomes from these interdisciplinary projects, because they tend to sometimes create more work for researchers than disciplinary specific projects, because researchers must learn new terminologies, new methods, but also look at things from a different perspective. So it's not easy as it seems, because you are having to explain your own language and approaches to colleagues from other disciplines. However, funding bodies now, in a lot of times now, explicitly call for interdisciplinary research proposals, but it is finding the right appropriate platform for networking that kind of is the challenge, and also finding the right people to collaborate with. Next slide, please. And then, so working internationally and interdisciplinary comes with kind of more challenges, because although there is increased support, as I mentioned, and perhaps increased interest from funders, at least in the global north, and there is support in many high-income countries, it's not really mirrored in low-middle-income countries. And different countries have different needs and priorities relating to AMR. And it's really important to note that when you are working internationally, to see what are the priorities. What you might think is a priority as a researcher might not really be a national or a regional priority in the countries that you are working with. And in our experience, we have found that the lack of available platforms for researchers from different disciplines to interact is really something noticeable, particularly in our partners from the Global South. And it really creates a dependence on external funders or external researchers to initiate this type of activity. The other thing is anti-AMR being labeled as a medical problem only, with little involvement from researchers in different disciplines other than medicine or microbiology. The issue of protected time, I think, is one of the main things that we have noticed through our work, through Tactic, is that in many institutions in the global north, there is a protected time for researchers to do research, and even perhaps for medics and pharmacists if they have a research role, whereas in the global south, it's very much an add-on. You have you're a pharmacist or you're a medic, you have your daily job, but the research you have to do in your own time, which is really challenging, because in order to do the research, you have to have time for it. Another thing is language, obviously, and English not being the first language of many researchers, and it might be difficult to communicate effectively, I guess. Issue with travel, and I think we've all, I think due to COVID, all noticed that the restriction of travel has really perhaps affected some of us in the way that we work. And then trust with access to and sharing of data, and it's important to acknowledge that in the challenges when you are working internationally. Next slide, please. So I'm just going to give you like a case study of a success story, if you like, through these international collaborations. And when we established Tactic, it was just to establish a network to be able to provide us with an opportunity to collaborate and to communicate with one another, to linking within the AMR study groups, to enable researchers to think of ways, how can we combine this diverse expertise within the network to create a research project. And we needed to come up with common research questions. And as I said, we had a huge diversity of researchers, so it was quite challenging to come up with common questions, and also a methodological approach where where all the stakeholders involved were equally contributing, rather than being a purely medical or microbiological question with some added social science on top. So we actually identified that generating high quality data was the main focus across all the disciplines, and has a particular importance in low middle income countries. Next slide, please. So then we established a research project on reducing the spread of antibiotic resistance across the Nile Valley. And this is to use, and how can we generate data, and how data is used, is generated really from the microbiology lab, how it is used, how it travels through the system within the hospital, who has access to this data, who uses this data, and also how is it contributing to local policies and guidelines, regional policies and guidelines, and also within global policy and guidelines, and relating to national action plans and global action plans. And we have focused, we have several work packages, if you like, that I have, and aims that we want to do through the future work that we're doing through our collaboration internationally, and trying to communicate now more widely within the One Health approach, to enable the communication and collaboration between the medical, veterinary, agriculture, social sciences sectors, and improve capacity, improve community engagement, and make projects that are locally relevant and sustainable. Next slide, please. So thank you very much. You're welcome to contact me if you need. I've added the link to the website, but also to the paper where we have spoken more in detail about the establishment and tactics. So if you want to read more about it, you're welcome to read it on the link provided. So thank you all.
Thank you so much for sharing your experience, Lena, and it's so great to see the diversity of the group that you had involved in this AMR project, and again, the different aspects that other people bring into these sorts of projects is so important when we're trying to tackle global AMR, isn't it? So thank you so much. I will move on now to our next speaker, who is Guilherme, and he joins us from Timor-Leste. So welcome, Guilherme.
Okay, thank you everyone for letting me to join this webinar, and good evening from Timor-Leste at almost 9 p.m. and then I don't know in another country. Okay, well, I'm Guilherme dos Santos Jimenez Suarez. I'm working with the Menzies as a account pharmacy and also a junior AMS pharmacy in Timor-Leste. So today I'm going to talk about the point prevalence survey of the antimicrobial use in Timor-Leste that we have conducted in 2020, also 2021, but I'm going to discuss the 2020. Next slide, please.
I think we might be having some problems linking with Guilherme. Are you still there?
Yeah, did you hear me?
We just lost it. You just dropped out for a little minute there.
The connection?
Yes, the connection just dropped off for us. You're back with us though now. Thank you.
Okay, next slide, or still this slide?
I would go back over this slide if you can. Thank you.
Okay, so from the first one, or continue the antimicrobial resistance?
From here is fine, thank you.
Okay, well, as we know that the AMR is the global problem, it is significantly, they will increase the morbidity and also mortality and then healthcare costs. Next slide. Okay, in 2018, the Menzies with the Timorese some the microbiology. So they have conducted some study. So they also that 150 isolated 154 from the urine, and also the 57 skin they isolated, that they were found at 44% that resistant to the gentamicin. Also 28% is resistant to the ciprofloxacin. Next. So the antimicrobial resistance and also the problem with the overuse of the antimicrobial and also inappropriate use of the antimicrobial. Next. So this study is the first time that the Menzies conduct in the Timor-Leste in 2020. There is no evidence regarding the pattern of the use inappropriateness of the antimicrobial at the hospital level in Timor-Leste. Next. So this is the pictures that in the some referral hospital. Next. Okay, the method that the hospital based on the cross-sectional point prevalence survey. So we conduct in the October 2020 until December 2020 in the 6 referral hospital in the Timor-Leste. The population in the Timor-Leste 1.3 million. So the big hospital era in the city, we call it in Dili, National Hospital Guido Baldares. So it's 274 beds, and also the 4 referral hospital, the total beds only 24, and then Bokau it's 75 beds. And also for our outcomes, the antimicrobial about the prevalence and also appropriateness of the antimicrobial therapy, and also the quality improvement, the areas concerned in AMS. So in the Timor-Leste, we don't have the AMS pharmacy, especially from the government hospital around the Timor-Leste. And then the means support like to do the activity like as AMS pharmacy in the some referral hospital in Timor-Leste. Next. So this is the features that all the referral hospital that we conduct 5 referral hospital also in the national hospital in Delhi. Next. So before every referral hospital, we 1 week for the trip, and also we have to introduce our objective, and then also the team that with the pharmacy research officer, also the doctor, mostly the Timorese, also some infectious disease, and then AMS pharmacy from the Australia. So we also collected the data from the antibiotic consumptions and dispensing process. We have to look at, like example, how many patients that use the antibiotic like previous, and all the antibiotic that we collected for every referral hospital. Next. So we also give the education, provide the educations to the healthcare worker in the 6 referral hospital in the Timor-Leste. So regarding the AMR also and AMU. Next. So the challenge that, as we know, that the first one is the COVID, because of the most patients, they are not going to the hospital, because at the moment the COVID was really increased, and then they may think that if they go to the hospital, and then they will infect the positive COVID, and then they're gonna have the isolation from the 14 days. That's why some people, if they get the sick, they are not going to the hospital, they just stay at home. And also that the cancellations of the visit, sometimes the restrictions and then lockdown. And also in the Timor-Leste, mostly the doctor from the Cuban. That's why handwriting is quite difficult for us to interpret. So otherwise we have to call the doctor who graduated from the Cuban, and then they can translate to us. In the Timor-Leste, most specialists, a doctor from Cuban are working in the Timor-Leste. And also in the Timor-Leste, because all the doctors from the Timor-Leste, Timorese doctor, who are graduated from Australia, Portugal, Indonesian, Philippines, some they come to the Timor-Leste, they French language. That's why when we do the point prevalence survey, we look the notes, the patient's notes. We have a lot of language, Tetun. We have the Timorese language, Tetun, Indonesian, and then English, Portuguese, and Spanish. Spain. That's why this is the challenge for us. And also, so we use the WHO or NAPS guidelines to, especially from the appropriateness to how many percentage that appropriateness, and also how many percentage inappropriateness, but we use the NAPS guidelines. Next. So also in the Timor-Leste, the meninges doctors and also with the specialists from the Timorese, they develop one antibiotic guidelines. It's only from the HNGB, not all the Timorese, because all the doctors in the Timor-Leste, they use the different guidelines from every country. That's why we want to interpret what guidelines that you are using for it. And then they say, oh, I'm use from the Indonesian guidelines, or some from Australian guidelines, or some from the Cuba guidelines. That's why make as a pharmacy, we don't know that which one we are going to follow. And also the challenge, also the durations, that mostly the doctor not recorded the durations. They only prescribe the antibiotic to the patients, but they don't know that when gonna stop. And also the charts, sometimes the chart is quite difficult to to see because all of them is handwriting. Some of the handwriting quite difficult for us to analyze. Next. Okay, this is the example of the prescriptions that sometimes the handwriting quite difficult. I think that the handwriting make us confused. Next. So, like example, the nurses, when they administer the medications to the patients, sometimes they have to signature, or otherwise they are forget and then they are not signature. And then when we go to confirm, they said, "Did you give already this patient this medication to the patients?" They say, "Oh, we already giving. Why you are not have a signature?" "Oh, we forget." That's why this is the challenge for us also. Next. Okay, the durations not mentioned in the medication chart. The doctor only prescribe how many antibiotic will use from the long, sometimes from 2 weeks, 3 weeks, or some until the 1 month. Thank you. Next. Okay, so the result that about the point proportions of the survey. So we identified 392 patients that we been surveyed, and then we found that 219 on antimicrobial. It's equal to 74% percentage. HNGB is the number that 259 patients, and then 188 on antimicrobial. The other is not on antimicrobial. So why 20 patients but 30 on antimicrobial, and then we record with the patients on antimicrobial. If the patient is not antimicrobial, we collect it, but we are not going to process it. Next. So after we collected the data from the patients on the antimicrobial, we are going to know that what indication that the doctor prescribed the antibiotic from the patients. Mostly the patients that on antibiotic that have community-acquired pneumonia and follow the neonatal sepsis and then surgical prophylaxis and postpartum prophylaxis and cellulitis. The most indication that the doctor prescribed the antibiotic to the patients based on that diagnosis. Next. So we also that the top the antimicrobial that prescribed. The ceftriaxone is the number 1, ampicillin, gentamicin, and metronidazole, and then cloxacillin. Next. So the class penicillin, cephalosporin, aminoglycoside is the only the class. And next. So when we identify, so we total is 290 patients, and then 162 only one antibiotic, on like ceftriaxone, only one ceftriaxone. And then we have 96 2 antibiotic, and then 3 antibiotic 12 patients, 4 antibiotic 8 patients, 5 antimicrobial is 7 patients, 6 antimicrobial is 4 patients, and 7 antimicrobial only 1 patient. Next. So the antimicrobial consumptions, every referral hospital, HNGB is the ceftriaxone. So they are using too much, and Suai is ampicillin, and then Mobesi also ampicillin, Baucau ceftriaxone, Maliana ceftriaxone, and Okusi ceftriaxone. Go next. So regarding, okay, the appropriateness of the antimicrobial. So we identified that appropriateness, we found it 66% and 33% that inappropriateness. Every referral hospital, they have the difference number. The HNGB 288, and then 72% is appropriateness and 23% inappropriateness. I think I'm not going to discuss every referral hospital because I think the time. Next. So quality improvement areas, because in the Timor-Leste, mostly the patients with the reported only pediatrics and also the TB patients, but all the patients that admitted to the hospital, mostly the chart that the nursing did not record the patient's weight. And also the microbiology, regarding the microbiology, only collected at 49 and 195 micro not collected because all the Timor-Leste 2020, we only have the 1 microbiology in the national hospital is the support by the menses, and all the referral hospital, we don't have any microbiology. That's why there is no micro data that collected. Next. And I say that the antimicrobial stop date reported only 11% and 85% not reported and missing for the route of the administrations mostly use the intravenous, oral, and topical. The intravenous is 81.3. Next. Yeah, the quality improvement areas. In the Timor-Leste, we need the Timor-Leste guidelines, especially from the antibiotic, so that every doctor come to the Timor-Leste, they have to use only one guidelines. And also the second is the use of the dosing guide to avoid the underdosing and then overdosing. And also reporting the patients the clinical information detailed while they prescribing the antibiotic. And follow the reporting the patient's weight to support the appropriate antibiotic dose. So availability and use of the microbiology service to identify the pathogen and directly antibiotic therapy. And then a step down from the IV to oral antibiotic when improved. And then next. And also the antimicrobial resistance, the activity, include the activity surveillance to inform the local and national guidelines for the empirical treatment. And then laboratories now being established in the referral hospital. So all the doctors, when they going to prescribe the antibiotic, they have to do the blood culture so that the patients, when the doctor prescribe the antibiotic based on the microbiology. And also the national antibiotic guidelines developed by the Timorese team. So I think that in this year, they're gonna release that antibiotic guidelines in 2022, so that all the doctors in the Timor-Leste, they are going to use the same one guidelines. And then electronic prescribing system in the futures. Next. I think that that's all for me. Thank you.
Thank you so much, Guilherme. It's really great to see, the challenges that you've been able to overcome in Timor-Leste and this great collection of data and the interventions that you're going to use with that data as well. So well done for all the hard work, because we know it's a challenge in most countries, but Timor-Leste obviously has some of its own individual challenges as well, along with guidelines and languages and availability, and travel. So well done. It's really great to see the impact that your work has had, and we look forward to hearing more. Thank you. So I'll lead on to our next speaker, who is Cornelius, who is joining us from Ghana. Welcome, Cornelius.
Thank you very much. So yes, I'd like to thank FIP and CP for the opportunity to talk about what we've been doing down here. The outline for my session will be as indicated. We briefly talk about our partnership, our very first AMS projects, our first Global Point Prevalence Survey, other data-related activities we've been up to, and then one thing. Next slide, please. Yes, so our partnership is one of the health partnerships under the Commonwealth Partnerships for Antimicrobial Stewardship School. We've been actively working as a partnership since 2019. As it is with these partnerships, we have a UK partner being University College London Hospitals. And from our local side, we have Full Teaching Hospital, and then the University of Health and Life Sciences, that is the only state university in Ghana, wholly dedicated to the training of healthcare professionals. Next slide, please. I'll talk briefly about our implementation sites. That is Full Teaching Hospital. So that is an aerial view of our facility. It is a tertiary healthcare facility and the main referral facility serving people in the border region of Ghana and beyond. Also being a facility in the border region, close to Togo, you tend to get clients from Togo coming in as well. The hospital has a bed capacity of about 300 with 14 wards. It has 5 clinical departments, that is internal medicine, surgical, obstetrics and gynecology, child health, and then public health. Next slide, please.
Cornelius, I'm really sorry to disturb you. Is there any way you can speak up a little bit? I think some people are struggling to hear a little bit.
All right. Sorry.
Thank you.
Is it better?
Yes, that's
Hello?
better.
Perfect. All right.
Thanks.
So for our very first project, which was on enhancing hospital pharmacist roles to support the delivery of antimicrobial stewardship programs in our hospital, this was an educational intervention project whereby we worked closely with experienced AMR pharmacists from our UK partner institution and experts in Ghana to learn about best practices when it comes to AMR and AMS. The initial focus was on pharmacists, but we made it as multidisciplinary as possible. With AMR being a multifaceted problem, AMS requires an all-hands-on-deck kind of approach to address it. And whenever we could, we included biomedical scientists, nurses, medical doctors, administrators, orderlies in our trainings for management impacts. Is the voice the most clear? I could see a comment like that. Frances, is it better? I don't know if it's from.
I can hear clearer, yes.
Okay, all right. Yes, so the initial focus, as I indicated, was on pharmacists, but we made it as multidisciplinary as possible because of the multifaceted nature of the problem and the fact that you need everyone to be on board to address it. Next slide, please. So our first point prevalence survey on antimicrobial use was in July 2019, and we scheduled this as part of a training on AMS. And as usual, we try to make the participation as multidisciplinary as possible. And being the very first time we're using the Global Point Prevalence tool, we're taking through the data entry forms, the inclusion and exclusion criteria, the web-based platform, and then how you generate your reports after data entry. Next slide, please. All right, so that is a group picture we took just before our very first survey. And an interesting idea we implemented during this was the wearing of t-shirts branded with various messages about antimicrobial stewardship. And we had messages such as misuse of antibiotics puts all of us at risk, handle antibiotics with care, the general messages you tend to preach to people about the subject. And this created massive awareness in the hospital with people asking lots of questions. I still do wear my t-shirts, and I've bumped into others on several occasions also wearing theirs. And the thing with this is you sort of speak to people about the subject without really saying a word. And also most of our members are active on Twitter. So whenever we are having these exercises, there's lots of flooding of Twitter with pictures of our activities, which creates lots of around our work. Yeah, next slide, please. So with some strong points from that exercise, AMS requires a teamwork, approach to be effective. So we engage various multidisciplinary teams in our data collection. For each team, there were at least 3 different professional groups. Talk of the biomedical scientists, the nurses, the pharmacists, or a prescriber. So, usually before entries are made, there's some form of deliberation with everyone bringing their view on board. And, this at the time led to limited errors during entry. The web-based platform is smart in the sense that it flags several errors which have to be addressed before results can be validated. And this at times can be a pain and time consuming because you have to go back to the folders in question. And, using these multidisciplinary teams helped us reduce these sort of errors. To date, all our point prevalence surveys have been on the whole facility, and we are usually able to get this done within the morning shift. So from 8 to 2 p.m., we can get this done. And one reason why we are sort of able to work effectively within a shorter period of time is because we allocate the nurses in all the teams we are working with in the wards in which they work in day to day. So it is sort of easy to navigate our way around when it comes to challenges on data retrieval. All right, next slide, please. So I'll highlight on some of the outcomes from our work. At the moment, we know the antimicrobial prescription pattern of our facility. The platform sort of breaks the data down into surgical, ICU, and medical, as well as adults, peds, and neonatal wards. So it sort of makes it easy to identify areas where intense stewardship activities are needed. And every now and then our findings are communicated to staff and management. And, all our publications, we try to put these on open access, publishing open access journals. Next slide, please. So we have one of such publications, which I think we published in 2020 or 2021, and that is freely available to be accessed online. The Global Point Prevalence Survey also serves as a good monitoring and evaluation tool to assess the impacts of our activities. So it tends to guide our continuous education on the subject as well. Whatever data is collected is also pulled together with other hospitals conducting the survey. So one can, at the end of the day, sort of get the regional picture as well as the global picture. And we have contributed to one of such works in the sub-region. Next slide, please. Yeah, so that is what we contributed to as part of our activities. And finally, for our facility, this also led to the development of local antimicrobial policy, which we have started implementing to ensure best practices when it comes to stewardship. Next slide, please. Usually with these kind of initiatives, ensuring sustainability is very challenging. So for us, what we did was we made a proposal to the senior management of the hospital to constitute an AMS committee. And this has been championing activities on the subject and then safeguarding antimicrobials. This committee, I must say, has been in place since 2020. And we always disseminate our findings to our constituents. It is important to let staff own the data and the findings, and this also serves as a good monitoring and evaluation tool. The objective of whatever we are doing is never to victimize any individual or professional group, but to identify areas that are needed for capacity building. Also, senior management has been in support of what we have been doing right from the start. They bought into our idea and they have been very supportive, and this sort of gives the staff the confidence to align with our objectives. Next slide, please. So to talk about other data-related activities we've been engaging in as a partnership, we have piloted a similar concept recently using Google Forms for outpatient prescriptions that have antimicrobials on. We have also recently developed an antibiogram for the hospital based on common microbes that are isolated from routine culture and sensitivity tests. The whole idea is to guide empirical treatments. We have also done some work to ascertain the disposal practices of healthcare workers in our hospital when it comes to unused antimicrobials. Next slide, please. So for my final words, I think data is very key in whatever we do in the hospital. After all, we want our practice to be evidence-based, and this is down to data. Secondly, teamwork is important for sustainable stewardship in addressing AMR. An individual or professional group cannot address this alone. We need to work together. And then as researchers, we need to make it a part of our way to disseminate our findings. There is no point conducting lots of research and leaving the data on shelves or our computers. We need to make our findings known. And then finally, we need to continuously engage the public on the subject. It doesn't always need to be a formal gathering. It could be educating our friends, family members, or whatever social groups we find ourselves in. As researchers and healthcare professionals, we can do our bit, but if the general public is not in sync with our objectives, we'll be fighting a lost battle when it comes to antimicrobial resistance. Next slide, please. Yes, so finally, I would like to acknowledge our partners and funders. Thank you very much.
Thank you so much, Cornelius. And one of the real things that stood out to me from your talk was about the sustainability. It's really using that data and, forming your AMS committees and really making sure you've got that leadership engagement and the buy-in to really take forward your AMS interventions and actually, make them sustainable in your organisation. So that's great to see, and well done for all the great work that you're doing in Ghana. Thank you so much for sharing. I'll move on now to our final speakers, who are Joe and Lucy, who are some excellent people who, even though they're not pharmacists, they are health psychologists who we work very closely with in the Commonwealth Pharmacists Association. Thank you, Jo and Lucy.
Thank you, Fran. Great to see everyone here. We're psychologists who are always delighted to work with pharmacists, and it's been wonderful to hear all the talks already today, and we can see lots of links with our work and our approach, and we love working with CPA in particular and all of you across all the projects. What we're going to talk about today briefly is just a little bit of our approach to how we work on behaviour change and how we think about that perspective of the excellent work that you're all doing and how we can help you to think about how that makes meaningful and sustained changes in practice. So I'm going to introduce a little bit of our approach, and then we're going to particularly talk about CQI and our approach to that. Next slide, please. Our first thing that I wanted to say to you was about how we think about just because we can do something doesn't necessarily mean that we will do something. So when we think about being trained to do anything in our professional practice, there's sometimes an assumption that just because we know how to do something, just because we have the skills to do something, that we will then be able to do it in practice, or we will then implement it in practice. And I think we all know that it is much more complex than that we are trained to do many, many things that for lots of reasons we then aren't able to do in practice. And so that phrase is really the basis of our work, which is thinking, how can we ensure that practice change does happen following training or any kind of intervention to make it meaningful. Next slide, please. So we're going to briefly talk about three things. So firstly, defining whatever a problem is that might have come out of the PPS work in behavioural terms and thinking about how to do that. Secondly, about how we explore the behavioural influences. So what are the things that are likely to be barriers or facilitators to the way in which we approach behaviour change. And thirdly, our approach to CQI. Next slide. So firstly, defining the problem in behavioural terms, and a lot of projects and groups will be thinking a lot about what is the issue that comes out of, particularly if you've done a PPS or you know that there's a particular issue in your hospital or in your local environment. And so if we think about this kind of behaviour, so specifying this kind of behaviour. So a recent audit has shown that patients on a surgical ward are receiving extended surgical prophylaxis when a single dose is recommended in the guidance. And so that's a fairly typical problem that we might see. So to define that in behavioural terms, we then think about all of the people and all of the things that might need to change that so that there is less surgical prophylaxis and it's appropriately given as in the guidelines. So what we might start thinking about is who needs to do that. So it might be the pharmacists having conversations, it might be the prescribers doing something differently. It's probably both of those groups of people and many more groups of people. It might be the nurses on the ward monitoring that and feeding back. But they also need to think very specifically about who needs to do who, how, when and where. So is it a change in the notes? Is it something that flags up after surgery or before surgery? And so there are many, many specific elements to think about in specifying a behaviour, making a really clear statement about a behaviour that is then likely to change practice. So when we think about behaviours, it's good to do that step back of how we're going to do this. Next slide, please. The second thing we do is really focusing on behavioural influences. So what are the kinds of things that to make it more likely and less likely that practice change can happen? So when we explore the influences of something like this problem on this slide, so a recent hospital point prevalence survey, of which many of you have been doing, have shown that course lengths for antibiotics are generally longer than justified in the guidance. What we're really interested in at this stage is why is that the case? So why might that be the case? And exploring that before we start any work is a really good idea. Next slide, please. So when we think about exploring those influences, here are some ideas that might come up. So we might talk to people involved in that process who are doing the prescribing, who are the pharmacists who are observing this behaviour, or the nurses on the wards who have seen this. And we start thinking about that in terms of these concepts of capability, opportunity, and motivation. And that helps us really think through how we might design an intervention. So capability is about knowledge and skills. So somebody might say, I don't know what I'm meant to do or how to do it. From a motivational point of view, so thinking about how people think about the outcomes and think about their own beliefs, or think about their habitual behaviour, think about what they usually do. So they might say something like these phrases in orange: I want to do it, but I seem to forget and just do what I've always done. Or I know what to do and how to do it, but I don't actually think it's a good idea. So those are kind of motivational aspects that might come through. And finally, opportunity. So somebody says, actually, my boss is telling me not to do it, or they think their patients will object to them doing it, or they don't have access to the stuff they need. They don't have the equipment or resource, or they don't have time. So by exploring influences from this behavioural perspective, you get much more detailed information about what intervention is likely to be effective. I'm going to hand over now to my colleague, Professor Lucy Byrne-Davis.
Next slide, please. So the question is what we do with all of that. So if we start from that sort of behavioural perspective that these things are influencing people, the question is how do we move forward with that? So when we think about continuous quality improvement, we think of actually the Plan, Do, Study, Act, or the PDSA cycle, which is actually over 100 years old when it was first instituted. And what that whole cycle enables us to do is to kind of step back from what we think might work. So it's basically trying to make us take a less impulsive approach to trying to improve things. So what we'll do is we sit down and we ask ourselves the questions of what it is that we want to achieve, how do we think we're going to achieve that using those behavioural principles that Joe has been mentioning, and we sit down and we make a plan, usually quite a small plan, and then we carry it out. Then we do it again in a kind of small way, and then the really important part is that we then study what's happened. Again, thinking behaviourally, what influences are changing, what behaviours are changing or not changing. And then on the basis of what we find, we then decide to act. So we might change the intervention that we've decided on because it doesn't seem to be working, or if it's working, we might think about rolling it out. So that's the sort of act part of it. And then we continue to do it. So I think sometimes the temptation is to rush in and to take a sort of very initial approach to what we think will improve things, whereas this is really encouraging us to take a sort of slower and more cyclical approach to changing. Thinking, as Joe and I both are as psychologists, we also want to think about how should we do that Plan, Do, Study, Act approach. So we've talked about taking this behavioural approach that Joe's mentioned, but how do we conduct ourselves when we're doing this kind of work? So the two big principles here are that our approach is appreciative and participatory. So I'm just going to explain what I mean by those two things. So when we're trying to improve things, it's very easy to focus on what's gone wrong, what needs fixing. And the big issue with this is that we're all people. Everyone who's working within the healthcare system is a person, and we all have our own emotions and the way that we respond to things. So if we are constantly being told that we're doing things wrong and that we need to improve, that can actually have quite a detrimental effect on our morale and our motivation to do things better. But we do need to find out what's going wrong. And so a different way of approaching that is an appreciative way. And it's a very small but significant shift in the way that we conduct ourselves in quality improvement. So rather than saying what's going wrong, that means that the prescribing isn't the way that it should be, we kind of say, what strengths have we got as a team? What opportunities have we got as a team to improve what we're doing? And so you're still focusing on the same issue, but you're taking this sort of appreciative, it's the things that you then focus on what you're good at and what your team has, rather than what your deficiencies are and how what's going is wrong. And there are, the link there on the slide, the David Cooper Rider link, really fleshes out this appreciative inquiry approach to quality improvement, which I really encourage you to have a look at if you haven't already. The second one of those two principles is about it being participatory. So we've all, as health professionals, been in situations where somebody has come in with a project, they've had all the energy and all the ideas, and we kind of go along with that project, and then that person leaves and things dwindle, things just decrease because the energy is gone and because the person who owned that project has gone. And this is why making things participatory is so crucial. It's to do with maintenance of change, really. A participatory approach means that you're not doing the planning and studying on those people, but that you're all doing it together. So it's all really about that really important kind of getting everybody's buy-in right at the beginning, you all studying everybody's influences on behaviour, you all making the decisions about how to intervene, and you all monitoring how that goes. And that really is that sort of participatory approach. So it's not that there's somebody leading it from up here, but actually that we're all participating in it together. And all I've added there to that to this slide as well is really the behaviour change wheel, which is the behavioural approach that Joe was talking about. If you look very carefully on the green circle in the middle, you can see the capability, opportunity and motivation that she was talking about there. So really what we're talking about is a sort of comprehensive approach to quality improvement. Next slide, please. And we can kind of distill this, because we all need to have small things that we can remember whilst we're doing our quality improvement. We kind of distill this into sort of 4 crucial principles, if you like. The first is about thinking about other people's emotions. So, you know, people are people. Everybody has feelings as well as what they plan to do and what they know what to do. And so really understanding that people don't like to be kept in the dark about things, so they like to participate, and also people don't like or don't respond well to being to having the things that they're bad at focused on a lot. Supporting people to take control, that's that participatory approach. The being curious, that's asking more questions and giving less information. So really attending to what those influences are on behaviour, and the fact that it's not just one big thing, that yes, we're turning the wheel once, but actually we're only going to get to our destination if we keep turning the wheel and we keep cycling. And I think that's the summary slide is next, and that's just to remind you that just because someone can doesn't mean that they will. And thank you for listening.
Thank you so much, Joe and Lucy. I learn so much every time I hear you talk, and you always give me different food for thought to go away with. So thank you so much for just giving that different perspective to just, you know, it's not just about the data in front of you and what's been prescribed and what's happening now. It's really about trying to build those quality interventions, isn't it, and make things sustainable so that you can actually impact on future practice, and really reflecting on where you are in your PDSA cycle and making sure it's a fluid process rather than just auditing and responding and, you know, not really achieving much in between, which I know I am very guilty of in the past as well. So it's always great to hear from you. I know that you have to leave us, I think, at this point, don't you? So thank you so much for being a member of our team today, and it's great to hear from you. So that will move us on to the Q&A, which my colleague Max is going to lead us in.
Excellent.
All right, thank you very much, Fran. I'll begin this by sharing an experience from one of our programs at the CPA. And this is the SPARK program, where we've had an actual experience of conducting PPS and using the data from the PPS to lead into action. And here we've focused on empowering the health workers themselves to do the PPS, of course, leveraging the strength that come with the GPPS method that Anne explained to us in the beginning. And we've gotten this empowerment across 6 countries in Southeast Asia and also Africa. And we've engaged the health workers in a diverse kind of manner where we brought into pharmacists, microbiologists, and nurses to really get to know how this PPS is conducted and collect the data by themselves, and also get it analyzed and use the results they have obtained to present to the wider team within the healthcare institution. And at that point, after they have received their data, we then engaged with Joe and Lucy to design a CQI template that rotated around the PDS cycle that Lucy and Joe have just taken us through, to make sure we leave something that is a bit more tangible that these healthcare teams can use to design their interventions based on the PPS data that they have received. And from this experience so far, this program is still running, but we've received some exciting actions, like some of the healthcare teams that have been engaged have reported they have also been really very surprised by the results they have obtained. They didn't expect that was happening in the very hospitals that they were working in. And also they have gone ahead to develop work plans as a team to see how they can get to change the situation of the practices from their hospitals. And some of them have gone ahead to start off thinking to solicit funds to support solve some of the challenges that they have obtained, say the minimum trainings from the limited training of the staff that needs to be lifted up to get them better in practicing better antimicrobial prescribing. Yeah, so that is it from what I wanted to share from our SPARK program at the CPA. I'll hand over to Fran and
thank you, Max. If we can have our panelists put the cameras on, I think we do have a couple of minutes remaining for some questions. Oh, I'm just sorry. So we've got a question from Luna, who's asked, what are the best assessment tools to use in community AMS programs and activities? I'm hoping you might be able to answer this one for us, Anne.
I heard Cornelius Dodo in Ghana has been developing a tool also to measure outpatients, antimicrobial prescribing in outpatients. It's really a very important topic because most antibacterials have been used and prescribed or used or dispensed in the outpatient setting. I can say that for the global PPS, we are also on the way to release an outpatient module. We started beginning this year already to develop the protocol and the data collection templates, and honestly, I thought it would have been easy, but it was more difficult than I thought, because we also reflected with a lot of our partners in our network in Africa, Nigeria, Burkina Faso, Togo, but also Vietnam, people from Canada, from Georgia, I mean, different partners we have worldwide wanted to see it reflected that these are the variables we need to know. So finally, I think it took almost a half a year that we come up with a protocol, and now it's been programmed in our software, because we have a web-based software, so it will be an extended module for the Global PPS, and hopefully we will launch it early next year in January. But I know that also WHO is working on that, and within the ADILA project, so there are a lot of people working on that. So I can only hope that we can maybe work together and share experiences to come up with the best way to improve dispensing or antimicrobial prescribing in outpatient settings. Yeah, it's utmost important. I don't know if that can answer your question.
I think so. Thank you, Anne. It is so important in the outpatient setting, isn't it? A lot of our tools are based in secondary care, and we know a lot of prescribing goes on in the community sector. Cornelius, did you have anything to talk about your tool that you have developed? All
right. So what we did was to just come up with a very simplified tool, because this data collection was ongoing whilst patients were at the window. So we didn't want to increase patients with time. So it was a very simple tool we developed, looking at pretty much the dose, the duration, whether the indication is compliant with standard treatment guidelines, and the number of antibiotics that were prescribed per patient. So very simple indicators to just get a picture of what is going on for the outpatient side. Pretty much.
Thank you. I'm just going to ask one final question, because I know we've run slightly over. Guilherme, are you still with us? Which tool did you use to evaluate your AMS activities in your PPS?
Okay, I think that you can see this one.
I think the background's blurring it slightly.
Okay, actually we use that point prevalence survey. It's by WHO.
The WHO one.
WHO. Also we use the NAPS. NAPS is the National Antimicrobial Prescribing Survey. It's from, I think, from Australia. Yeah, we use the WHO and NAPS.
Great, and that's the thing. There's so many different tools out there, isn't there? That it's important to really think about which is the most appropriate one for your setting. And I know we've used a lot of our projects have used the Global PPS tool because we considered that fitted best with the programs that we've really supported in terms of the analysis that you and your team can provide, and so which is very valuable to our settings. I'm going to bring this to a close now, so I'd just like to really thank our speakers, and before I hand over to Lars to give his final closing remarks, I just really wanted to say how great it is to see how many people have attended today from across the globe, and the real enthusiasm in our speakers and the real enthusiasm in our participants to attend today. Everyone's really busy, but it's great to see us all coming together to share our practice and to think about how we can improve the quality of our data and our AMS interventions to influence the use of antimicrobials on an international scale. I really hope we've given you some food for thought onto how you collect the data locally and how you can use that, because it's really important for our end goal, our ultimate goal of sustaining our precious antimicrobials for our future generations. So it's a big thank you from me, and I will hand you over to Lars.
Thank you so very much, Francis. Well, I think it's very obvious that data is key to understand the AMR burden and to evaluate the response. So quality data is essential to inform and evaluate the AMR response at local, national and global levels. And it's crucial to collect comprehensive country-specific and global data to monitor the emergence and spread of antimicrobial resistance. So with respect to this, progress depends on commitment, collaboration, and sustainable developments. And I hope that tackling the antimicrobial resistance will be easier to handle than the climate change, because this matters to everyone on the planet, and everyone has a role to play, whether it's the patient, the clinicians, the private sector, healthcare systems, governments, and pharmacists. And perhaps we need to handle AMR as we actually treated the pandemic, to handle AMR and AMS as a pandemic treaty with a fast global response as the result. So I also would like to emphasize data tracking and call for increased education for both patients and clinicians to better understand the issue. And that is also something we recently heard about. So perhaps next slide, Ali. I would like to encourage you to join our next session regarding antimicrobial stewardship, communities in action, a most exciting event as well on November 11th. So please join us at that session. And finally, I would say a special thank you to our most distinguished speakers for sharing their experiences and wisdom linked to today's topic. And also a special thank you to my co-chair, Francis. It has been a great honor to and pleasure to co-share this event with you both and Maxensia as well. So thank you, CPA, for delivering these events with the International Pharmaceutical Federation. It is indeed the most important topic, a silent pandemic, where we all can learn a lot by attending all 6 sessions. And together, we can actually create a very interesting and most important future for all of us, because the world needs all the illumination it can get. And you, every one of you who has been attending this event today, are the sparkles that can illuminate the world. And when it comes to AMS and AMR, so that we can create a more sustainable healthcare system and a brighter world for all of us. So thank you so very much, all of you, for attending this event today. And I look forward to meet you, everyone, all of you, on November 11th. Thank you so very much. And I wish you all a very nice weekend. Goodbye.
Goodbye.
Obrigado, thank you.